Ladies and gentlemen, good evening to everybody. We are coming tonight to our regular Sunday Mega Online Course in Anesthesia webinar. Tonight is episode 17 or 17 session in 2021. I'm so proud to be in this position, continuing our online anesthesia medical education. And tonight here we have three guest speakers, and we have our excellent distinguished moderator, Dr. Omar Elabbasy. Dr. Omar Elabbasy is graduated from Cairo University, and he jumped across the river to get his master's degree from Ain Shams University. Then he went to Saudi Arabia, and he worked there. He got his DIAC exam, European Diploma in Intensive Care and Anaesthesiology, and he moved. He got his membership and his fellowship of the College of the Anesthesiologists in Ireland, and he was working as a consultant in Saudi Arabia, and then he moved to Ireland. Now he is a senior registrar in Bowman University Hospital, one of the biggest tertiary hospital referral center in Dublin, in Ireland. And I'm so proud to have my colleague tonight, Dr. Omar Elabbasy, as the distinguished moderator here, and all the floor to you, Dr. Omar. Thank you very much for coming here.
Thank you very much, Dr. Saad, for this nice presentation and introduction for myself. I'm really proud to join the Mega Online courses, and I would like to thank all the attendee in this webinar tonight, and for wherever you are. And I'm so delighted to introduce three of our distinguished and talented colleagues who are joining us from different parts of the world to share their experiences with us. And tonight we welcome, first of all, Professor Dr. Samir Elansary. He's a professor of anesthesia and intensive care in Ain Shams University, Cairo, Egypt. Prof Elansary will talk to us about ICU perils, and we are looking forward for all his experiences and advices in ICU.
Good evening, my dear colleagues. Thank you, Dr. Omar, for your nice introduction. Today, I am going to speak about the brain injury management in ICU. And I think most of us know what is the plan for management of those patients suffering from brain injury. And I think the main item of management is how to decrease the sequelae of secondary brain injury, how to restrict the injury to the primary injury only, and not to extend the other complications leading to secondary brain injury. And I think the main purpose also is to discuss how to decrease the intracranial pressure, which is the end result of brain injury, and the increased ICP really is very dangerous and destructive to the brain tissue. I think this case will demonstrate how much the ICP will affect the brain tissue. This elderly gentleman was admitted with a known right giant middle cerebral artery aneurysm. He deteriorated on the ward, and his repeat CT had shown bleeding. We have to identify from this CT film what is the feature of mass effect for in that patient. And I think we can see here the bleeding, the intracerebral bleeding from the middle cerebral artery injury, and the deviations of the midline and the compression of the right ventricle, and even the gray matter, gray-white differentiation is lost. And this is the main signs elicited through CT for any patient suffering from mass effect or from increased ICP or intracranial pressure. Is again, this is the bleeding and the midline shift and the compression of the right ventricle, and differentiation lost for gray-white differentiation is lost, and so the patient suffering from increased intracranial pressure due to mass effect, which in this case is blood bleeding inside the parenchymal tissue of the brain. What is the causes? We have to ask ourselves, what is the causes of elevated ICP? Maybe intracranial, primary causes, maybe extracranial causes. Primary intracranial as traumatic brain injury, which may be contusion, epidural, subdural hematoma, the brain tumor, intracranial hemorrhage, ischemic stroke, large hydrocephalus, obstruction of the circulation of CSF, infection of the brain tissue, status epilepticus, increase the metabolic rate and increase oxygen consumption and carbon dioxide accumulation. Idiopathic may be idiopathic increase ICP, maybe post-operative after neurological, after neurosurgeries, patient may suffering from hemorrhage, edema, CSF disturbance, and so on. The extracranial causes which we must control it and which can be controlled and which can lead to secondary brain injury is the hypoxia, hypercarbia. So normal ventilation here is very important. Hypertension, hyponatremia, and electrolyte disturbance may lead to increased ICP. Hyperpyrexia and fever, we have to control fever. Seizures activity also increase the metabolic rate and increase the ICP. Hepatic failure or hepatic encephalopathy, drugs and toxins like any drugs leading to encephalopathy. Jugular venous obstructions also can decrease the venous return and abolish the venous compensatory effect after increasing ICP. High altitude and cerebral edema. All these factors can lead to increased intracranial pressures, and we have to be oriented with them, and we have to manage all of these factors. As you see here, this is subepidural hematoma, intracerebral contusion, there is subdural hemorrhage here, here is also subdural. We can see here also subarachnoid hemorrhage, here is subdural, intracerebral bleeding, hydrocephalus, maybe obstructions or blood clotting in the CSF pathway. Concept of brain injury, as I started and said, primary injury, which is primary injury affects the area of maximum neuronal damage. It will be surrounded by area of, we call it penumbra, which is less injury and potentially recoverable neuronal tissue, which can be recovered after supportive treatment of the brain. Secondary injury is the main item and the main purpose of management to decrease the secondary injury following the primary injury and causes further neuronal damage. And all of us, so many patients coming to ER, they talking oriented, and after 1 hour, 2 hours, they becoming comatose and the score is decreased. Secondary brain injury, the main factors which affect it or leading to secondary brain injury, of course, the hypoperfusion, hypotension, high intracranial pressure, ICP, decreasing the cerebral perfusion pressure, also any vasospasm in cerebral vessels. Hypoxemia, if it is dropped below 60 millimeter mercury, harmful mediators due to reperfusion and inflammation, electrolyte changes like state of hyponatremia, sensitive or rapid management of hyponatremia and other electrolyte disturbance. And I think all of us oriented with the pathophysiology of increased intracranial pressures, and we know what is the compliance, brain compliance, which is related to volume to pressure relationship, and elicit how much the extent of the capacity of the brain to compensate for increasing ICP or for increasing volume. And according to Monroe-Cayley doctrine, he says that the brain is defined as a box, fixed box, incompressible space. That the volume inside the cranium is fixed. And so any increase in the content of the brain, which is the brain tissue and arterial blood, venous blood, and CSF, any mass effect here will affect one component or affect the other component, and so there must be compensation, I think, mostly first by the venous blood, and followed by CSF compensation, or diverted to another way, or decrease the secretion from choroid plexus. And also after that, the blood volume will be decreased at the end to compensate for this increase in volume. But if the volume is increased too much, of course, the intracranial pressure will go up and increase the intracranial pressure. And don't forget the percentage nearly of the different components of the brain. Brain represents about 80%, and the other blood also 10%, and CSF is average 10%. In management of the brain injury, it is ABC management, like any resuscitations in the ER, maintain oxygenation, maintain the airway patency, try to clear the airway, try to insert intratracheal tube if the patient is suffering. Breathing, try to keep it normal breathing, not hyperventilation, hyperventilation. Also, the circulations we have to compensate for any blood loss or any fluid requirements must be reduced. Secure the airway and intubate if the Glasgow Coma score, which is a popular score, which we depend on it for evaluation of our neurological patients. If less than 8, we have to intubate our patients, and we have to support the breathing of the patient. Hypoxemia less than 60 millimeter mercury increases poor outcome from 28% to 71%, especially in trauma patients. Neurological intensive care monitoring, of course, we have according to hospital facilities and according to the facilities available in our hospitals, we have to report the oxygenation, so oximetry, the carbon dioxide through tidal CO2, all the other routine monitors like blood pressures, like heart rate, electrocardiogram, temperature, very important, blood glucose, and the chemistry of the patient must be corrected, and fluid intake and output, and the other devices like ICP monitoring. Of course, it is very important in certain patients who are eliciting some severe injury or score less than 8, or the CT show too much edema, as the case which we show at the first. And so also for catheter, central venous catheter, pulse oximetry, capnography, all these items of monitors are very important. And if you have non-invasive also devices to show you the intracranial pressure and the cerebral blood flow, like which depend on transcranial ultrasound, like ophthalmic artery blood flow, or the tympanic membrane deviation, or the other items inside the brain through transcranial ultrasonography will be very good, and you will achieve a good help from these devices. Post-traumatic indications for ICP monitoring. ICP monitoring are not recorded in every patient subjected to neurological trauma or suffering from neurological injury. But on those patients with Glasgow Coma scale less than 8, or abnormal CT scan, like show large hematoma, confusion, edema, compressed base stern, even if the CT is normal and the patient suffering from 2 or more, like is old age, over 40, suffering from unilateral or bilateral posturing, systolic blood pressure less than 90, unable to perform serial examination, like patients will go under continuous sedation and neuromuscular blockade, or the patient is comatose. I think all these patients require ICP monitoring to predict early what is the ICP and to interfere as soon as possible. Symptoms of increased intracranial pressure, especially if the patient is coming awake, they will see change in behavior, headache, lethargy, seizures activity, vomiting, without nausea, decrease in consciousness, neurological abnormality like abnormal eye movement, double vision, numbness. All these signs could be elicited, especially in awake or seen in awake patient. Cerebral herniation is the end of the scenario. Shift of the brain tissue from normal anatomic locations, and we must be oriented with the locations of the herniation, maybe transcalvarian, maybe subphalangeal, maybe central, maybe ankle, maybe tonsillar, and so we have to be oriented with and as we know, the brain is restricted by rigid neural structures as spherical circular and tentorial circular, and the change of the brain position, we consider it herniations, and I think most we are oriented with main symptoms: bradycardia, hypertension, pupillary changes, and so at this time we have to interfere either by medical interference or surgical intervention. ICP monitoring may be invasive and may be non-invasive, and we have different sites to insert our catheters for EVD monitoring of our patient or monitoring the ICP. We can insert it in intraventricular, and I think this is the gold standard, or maybe intracranial, or maybe subdural, epidural, and it depends on different modalities, really. Maybe fiber optic, maybe fluid coupled, maybe microchip, maybe air pulse, and it may be a cranial position or lumbar position for estimating EVD or estimating the ICP. ICP-based management was more efficient in terms of shorter ICU treatment course and fewer interventions to achieve the same outcome and less mortality. And as you know, our ICP must be less than 20 or 22 millimeter mercury. We can measure it in millimeter mercury or in centimeter water, but really I prefer the millimeter mercury to coincide or compare with the arterial blood pressure. A change in intracranial pressures have been shown to depend on 4 variables: CSF production, rate of CSF production from choroid plexus, how much, and its absorption; intracranial compliance, which is the relation between ICP and the volume state of the brain; outflow resistance, or especially of the venous blood, so the jugular and also the CSF; intradural sinus pressure. And these are the main factors which affect the ICP. Physiological elevation of intracranial pressures, which are briefly like in coughing, head down tilt, or neck vein compressions, especially if they are less than 2, 3, 5 minutes, not affecting the brain tissue too much, but it is important also to consider these factors during the management of our patients and decrease the recurrence of these bouts of short increase in intracranial pressure, which may affect the patient. Under dynamic equilibrium, the normal range of CSF pressure is between 5 to 15 millimeter mercury, or 7.5 to 20 centimeter water in adult. In children, of course, it is less, and in unit may be up to 6 millimeter mercury. The change in volume of the component is a decrease in cerebral blood flow or herniation of the brain if there is no compensation from the CSF and from the cerebral blood flow, especially the venous blood. The venous blood is, or the venous system is the most compressible one, and so it is the first one to compensate rapidly for any increase in mass effect or in ICU. The EVD, or external ventricular drain catheter, is most frequently placed by the way of twist drill, craniostomy, placed at Kocher point, locations on the frontal bone, mostly on the right side. It may be inserted on the left side, and maybe sometimes bilateral. It is inserted in the frontal horn of the lateral ventricle or in the third. Similar to a lumbar puncture, an external VD. It can also be based not only monitor the intracranial pressure, but also to drain CSF in some situations, but avoid in cases of mass effect, may increase the possibility of herniation. Also remove blood products from the ventricular space, especially in cases of hydrocephalus, obstructive hydrocephalus. The catheter is typically inserted in the right side of the brain. It may be on the left, maybe bilateral. EVD complications, of course, common. Maybe bleeding, maybe malplacement, may be inserted through a wrong pathway, and it may injure critical brain regions like internal capsule, brain stem. Malplacement can be symptomatic, and so the person which is qualified in its researcher must be the one to do that. Obstruction of the castor or the EVD by the blood clotting or by kinking of the tube is one of its main complications. And the brain at that time will swell, of course, and migrations of the castor is one of its complications. So it must be fixed subcutaneously and tunneled subcutaneously and fixed and secured with surgical sutures or surgical staples. Infection common care if we not insert under complete aseptic precautions. The EVD is a foreign body inserted in the brain, and as such it represents a potential for serious infection. Neurological, although neurological deficit from passing the EVD castor across the brain are uncommon, there can be an association of patients poor neurological status with EVD malplacements, and sometimes we saw neurological complications introduced by the malposition of the castor, and just to remove the castor, the patient may accept something. Today, of course, we depend on non-invasive intracranial pressure monitoring, and I think it is more better, which depend on the transcranial ultrasonography, and it is a very good technique which give us an idea about the blood flow, how much is the cerebral blood flow, how much is the deviations, and so we have many devices. Interpretation of ICP waveform very important. What is the causing this wave? May the underlying mechanism may differ, but it is mostly reflected from the choroidal artery blood flow or from the blood side the choroidal plexus. And the castor, of course, must be zero at first, and the level at the external uterine hiatus, which is equivalent to circuit of Wellness, and its preparations and adjustment must be important to give a good, to give an accurate reading, and we can use it as a drain, as we said, for to decrease ICP in some patients. This is the wave, or which is we see through recording the P1, which is the systolic peak and the tidal peak P2, and the P3, which reflect aortic valve closure peak, and this is the respiratory movement transmitted through the monitor. And if this P2 increases in size more than P1, this is an early indication of increased intracranial pressures, and we have to start rapid management to lower this high ICP. This is the pressure volume, or the compliance brain compliance curve, and as we see the relation between intracranial pressure and the volume of the brain tissue in this area. The brain is compliant brain, and an increase in volume not affecting the brain tissue, but increasing this area here is starting to be borderline compliance of the brain, and an increase will increase the ICP dramatically. Here is non-compliant brain, and an increase in volume, even small increase in volume, will increase the ICP too much. As we see, this reflects the wave here, increase the P2 amplitude, which is more than P1 and P1 suppressed. This meaning reduce the intracranial compliance and increase the intracranial pressure. And so we must be oriented with this wave for good interpretations of our brain ICP monitor. This also reflects this is a normal wave, P1, P2, P3, and here it started P2 to increase in potentially pathological state, and also here is a pathological P2 more than P1 and P3 started to go up. This is a round wave, and these are, I think, these D and E are pathological and reflecting increased brain tension. As we see increasing in intracranial pressures here, so can decrease the cerebral perfusion pressure. And as you know, cerebral perfusion pressure equals the mean arterial pressure minus the ICP or minus the intracranial pressure. And so any increase in intracranial pressure will affect the cerebral perfusion pressure. And so in such situations, don't try to drop or decrease the blood pressure. The blood pressure is increased in such situations. It is a normal reflex actions to compensate for cerebral perfusion pressure and to maintain cerebral pressure. And so don't be hurry in decreasing the arterial pressure in such situations. If the ICP trace is flat, maybe the tube, the catheter may be blocked or the patient. When to pull back the EVD out, at what time? If the patient exhibiting improvement and the blood, the ICP becoming normal, 20 or 25 or less, or if there is any infections in the catheter or the site of insertion, you have to ICP catheter. Pathological waveform also, if the include A, B, and our waves known as London Burge, A, B, and C. This wave specifically, which A wave is bad prognostic sign, it indicates the high ICP may reach 30 to 50, 40 millimeter mercury and may stay for 3 to 5 minutes. And this wave really is a pathological wave, and we have to push medical treatment to decrease ICP in such situations. London Burge B and C waves mostly reflect the vascular tone of the cerebral vessels, and B wave indicate the pressure may be range from 20 to 30 and they stay for 2 or 1 to 2 minutes. The C wave, I think it is reflect vasomotor tone only and not so pathological. Circulatory consideration, as we started, we have to maintain ABC or manage according to ABC, airway and breathing and circulation. If the patient exhibiting some systolic hypotension less than 90 millimeter mercury, we have to replace the blood, we have to give fluids, we have to give pressors in some situations. And in such situations, we prefer norepinephrine more than dopamine. As you know, dopamine causing is arrhythmogenic, and we prefer norepinephrine first. Norepinephrine, one of the vasopressor, natural vasopressors, which improve really the micro circulations and give us good results. Avoid hypotonic fluids in brain injury because you will worsen the cerebral edema and increase the cerebral edema. Prefer to use normal saline, and as you know, cerebral osmolarity, serum osmolarity of saline about 308, in contrast to LR, which about 273, which is hypotonic and leading to increased cerebral edema. Also, don't use glucose infusions. It will lead to increasing cerebral edema. 3% saline is considered more better and more preferred in risk stations because it is hypertonic solutions and also used in cases of hypovolemia, and so may give good results and not leading so much to hypotension or hypertension. Increased blood pressure, again, may be a sign of increased intracranial pressure. Don't treat or over-treat blood pressure alone. You have to consider the ICP, because if ICP is increased, you need a high blood pressure to compensate for maintaining normal cerebral perfusion pressure. Is intact autoregulations or the cerebral blood flow, arterial blood pressure curve, which shows the area of normal autoregulations of the cerebral blood flow, and this is the area of ischemia, lower cerebral perfusion pressure, and this area, if increased blood pressure, will lead to edema and increased cerebral perfusion pressure, which lead to RDS and even to more injury physically. The normal cerebral perfusion pressure normal is about 70 to 100 millimeter mercury. Adequate is from 50 to 60 millimeter mercury. If less than this, will lead to brain ischemia, and even less than 20 millimeter mercury to brain death. And so you must consider these items So in monitoring the ICP in critically ill patients or critically neurological ill patients is very important to maintain the cerebral perfusion pressure and cerebral. Suppose the intracranial pressure is increased exceeding 22 millimeter mercury, we have to interfere and we have to be ready for all these maneuvers. But we will not use all of these maneuvers at the same time. We can start first by head-up positioning to up to 25, 30 degree head-up. Some afraid really from positioning the head-up 30 degree may decrease the cerebral blood flow and leading to brain ischemia, but mostly or most of the team agree for raising the head for 20 to 30 degrees. Pain therapy is very important really to decrease anxiety and decrease pain and to decrease tension and straining and so on. Very important. Although opioids may lead to increase the intracranial pressure, but we have to sedate our patients for benzodiazepine or propofol, and always try to select the short-acting drug like benzodiazepine. Can use Dormican. Propofol is very good short-acting, but take care, don't exceed 2-3 days of propofol infusion. And if you find your patient exhibiting some acidosis with propofol, you have to suspect the propofol syndrome and you have to stop it because it leading, as you know, propofol syndrome leading to severe acidemia and renal impairment and so on. Carbon dioxide pressure also through hyperventilations. We now prefer to keep the patients normoventilated or carbon dioxide in the level of 30 to 35 millimeter mercury, not below. Otherwise, you will suffer. The cerebral vessels will be vasoconstricted and lead to brain ischemia. Cooling effect may be very important. Any fever, increase in fever will increase the metabolic rate and increase consequently the blood flow and the blood pressure. And so try to treat any fever with antibiotic or even antibiotic if you suspect infection. Osmotic also as mannitol or hypertonic saline. After that, if the patient not responding and agitated and you have to calm him more, you can use paralytic, especially if the patient is shivering to decrease the metabolic rate, but don't use excessive doses of muscle relaxant. Otherwise, you lead to neuropathy and polymyopathy of those critical patients. Pentobarbital, we using it lastly if the patient not responding to previous maneuvers, we can use pentobarbital, but take care of hypotension and failure. CSF drainage lastly and low diuretics may be used. Lastly, we can go to surgical decompression or to hemicraniectomy and refractory increased ICU. Some authors, as I said, I go now rapidly through some hints, very important pearls according to these previous drugs which we said. Very important points, we have to highlight it. Others, some authors have advocated keeping the patient head flat to maximize cerebral blood flow and the cerebral perfusion pressure, and afraid from cerebral ischemia from raising the head. But really, it is not so harmful and better to raise the head to 20, 25, 30. Don't increase the elevation more than this. Abdominal pressure, very important. You have to control the abdominal pressures, and even some go to fasciotomy, abdominal fasciotomy to decrease the abdominal pressures in some patients, especially those suffering from associated increased abdominal pressure or abdominal compartmental syndrome, because it will increase the venous pressure and retard the venous return from brain. Drugs like carbonic anhydrase inhibitors, very important as acetazolamide, they can decrease the secretion of CSF from the thyroid reflexes. Lumbar punctures, we can go to draining of CSF from through lumbar puncture, but take care in cases of mass effect which may lead to herniation. Sedation and analgesia, agitation and pain may significantly increase the blood pressure and the ICP. In general, benzodiazepine really is a brain protector. effective and very good in sedating the patient and decreasing the metabolic rate and reduction of cerebral metabolic rate of oxygen consumption, and it decreased cerebral blood flow with no effect on ICU. Where narcotics have no effect on cerebral metabolic or cerebral blood flow, but have been reported to increase in some individuals. Sedatives should be minimized, of course, daily. We have to make subject the patient to spontaneous breathing trials daily and awakening trials and stop sedations to evaluate our patient, especially neurological state. And as I said, selection of shorter acting agents is more better for controlling sedation and analgesia in such patients. Hypertension, elevated blood pressure is seen commonly in patients with intracranial hypertension, especially secondary to head injury, and is characterized by systolic blood pressure increase greater than diastolic, mostly affected the systolic blood pressure. It is associated with sympathetic overactivity, and so we have to control this blood pressure, but take care, as I said, start from decreasing the blood pressure too much in such situations of increased intracranial pressure, which will lead to decrease in cerebral perfusion pressure. And so the management is more controversial and may need to be individualized for each patient. When pressure autoregulation is impaired, which is common after traumatic brain injury, systemic hypertension may increase cerebral blood flow and ICP. Elevated blood pressure may exacerbate cerebral edema and increase the risk of post-op intracranial hemorrhage. A systemic hypertension may resolve with just sedation, and so if the decision is made to treat systemic hypertension, the choice of antihypertensive agent is very important. And so don't use the vasodilator drugs like nitroprusside and nitroglycerin. All these drugs will lead to vasodilatations and increase the cerebral blood flow and increase ICP. But better to use the sympathetic, sympathomimetic blocking drugs, especially short-acting beta-blocking drugs like levotiroxine, ismolol, or central-acting alpha receptor agonists like clonidine or dinosudine. All these are preferred than the vasodilators. And agents with a short half-life have an advantage when the blood pressure is up. And so we prefer always in our ICU, especially if we give drugs through IV infusion, we have to use the short-acting drug. Anemia also, as we know, leading to hyperdynamic circulation and increases in cerebral blood flow and ICP, and so try to treat any anemic state. And we prefer the better to restrictive transfusion, which our selection will at 7 grams per deciliter. We can increase to 10 grams our target to 10 grams per deciliter if the patient is suffering from some cardiovascular disease or some ischemic heart disease. Seizures prevention, very important in increased intracranial pressure and neurological injury, and especially some patients or many patients suffering from subclinical seizures activity and later seizures activity, and so we can use phenytoin or anticonvulsant drug like phenytoin or levetiracetam for just 7 days. But in late surgery, we can use more than 7 days, but mostly we use it for the first week only. We give just a heavy bolus dose of phenytoins, and then after that we continue with 100 milligram TID of phenytoin. Heavy sedation and paralysis generally in ICU patients avoid heavy sedation and avoid paralysis, too much paralysis, and just we can give drugs which will not affect the neurosurgical disorders like vicuronium and cisalpicorium. It is selected for such situations, and consider and put in your considerations paralytic agents plus sedation plus long-time immobilizations plus corticosteroid plus critically ill infection in your patients. All of these predispose to ICU syndrome of myopathy and polyneuropathy. And so I think better if you start to give neuromuscular blockade, don't paralyze the patient fully. or abolish that train of 4 completely. Just keep 2 spikes of train of 4 or 3 spikes, and just keep the patient compliant to could be managed without agitation. Also, we can shift after that to osmotic stations using mannitol or hypertonic saline 3%, intravenous bolus administration of mannitol to lower the ICP in 1 to 5 minutes, effect, with a peak effect at 20-60 minutes. The effect of mannitol on ICP lasts from 1.5 to 6 hours, depending on the clinical condition. And 3% hypertonic saline also we can commonly use to decrease the cerebral edema, and can be administered as 5 ml per kg bolus or as a continuous infusion. And monitoring serum sodium to be less than 160, very important, and also the osmolarity of the serum must not exceed 320. Otherwise, you will subject your patient to renal problems and to osmotic problems also, which may be reflected in increasing brain edema, not decreasing. The osmotic effect of mannitol increases serum tonicity, which draw edema fluid from cerebral parenchyma. This process takes 15 to 30 minutes till gradients are established. Try to keep the serum osmolarity less than 320, and don't exceed, otherwise the patient will suffering from hypovolemia, hyperosmolarity, and renal failure. And so when you start to use osmotic management, you have to record the serum osmolarity in your sheet, and you have to follow the volume status of the patients and also the renal functions and so on. Doses of mannitol mostly from 0.25 gram per kg to 1 gram per kg body weight. And really, I advise you don't exceed these doses and don't use too much high doses of mannitol. Otherwise, you subject your patient to many problems. We may use high dose in critically increase the ICP, but not for a long time. And mostly we use it only for 3 days. Others use it up to 5 days, but really we prefer 3 days. When long-term reduction of ICP is needed, we can use 0.25 to 0.5 gram per kg, can be repeated every 2 to 6 hours. Mannitol also has other actions, like it improves the rheological state of the blood cells and decrease the osmotic and improves the osmotic effects and increase the blood volume and the reduction of hematocrit and decrease blood viscosity, and it is antioxidant at the same time. So we prepare it in some state of severe infection. Systolic blood pressure less than 90 should be avoided in such situation. In patients with intact pressure autoregulation, the infusion of mannitol induces cerebral vasoconstriction, which maintains cerebral blood flow constant and decreases ICP pressure. But in patients with absent pressure autoregulation, the ICP is less, decrease in ICP is less pronounced. And so I think the osmotic medications here differ from patient to patient and according to the patient. And you have to predict your patient improving with the first dose or second dose or not. And also through follow up with CT, you can predict if your patient improves or not. Because we see really many patients are deteriorated after this osmotic management, especially with 3% hypertonic saline. And so not advisable to use osmotic medications in all patients suffering from neurological injury. Only those patients suffering from increased ICP. Mannitol opens the blood-brain barrier, and that it may aggravate the vasogenic edema because it is an osmotic factor, especially if the blood-brain barrier is disturbed. For this reason, when it is time to stop mannitol, it should be tailored to prevent the rebound cerebral edema and ICP increase. And so extended period of infusion of mannitol is not advised. Hypertonic saline also an osmotic factors, which used especially in patients suffering from hypovolemia because it is a resuscitating factor, and so increase the intravascular volume, and especially in hypovolemic or bleeder patients. Adverse effects of a hypertonic saline, of course, it may lead to coagulopathy and bleeding tendency, and prolong the coagulation time and hypokalemia and hyperchloromic acidosis. Don't forget hyperchloromic acidosis in such situations. Also, in patients suffering from hyponatremia, take care of using too much 3% saline. It will lead to central pontine myelinolysis, as we explained in Seydish syndrome, because rapid correction of sodium will lead to this central or neuronal injury. Hyperventilation also decreases arterial CO2, which can induce constriction of cerebral arteries by alkalizing the CSF. The resulting reduction in cerebral blood volume decreases ICP. The vasoconstrictive effect on cerebral arterioles lasts only 11 to 20 hours because pH and CSF rapidly equilibrate to the new arterial CO2 level. In hyperventilation, don't use hyperventilation except in acute situations. Or at start, you can decrease your, you put your patient on the ventilator, you start hyperventilation, keeping your arterial CO2 30 to 35 millimeter mercury, not less than this. Otherwise, you will vasoconstrict the cerebral vessels and you will subject your patient to more ischemia. Don't use too much hyperventilation in the subsequent days. Otherwise, you will increase intrathoracic pressure and increase in the beat, and you will impair the venous return, and you will get a bad effect on the brain of the patient. And so it is a time limited, and we prefer to use it just only kill the other factors which we can decrease by the ICD take action. As the CSF pH equilibrates, the cerebral arterioles redilate again, and possibly to a larger caliber than at the baseline. And so I prefer hyperventilation only in the first few hours, 12 hours, 10 hours. After that, go to the other methods of decreasing your ICP. Periodic episodes of hypoventilation also can precipitate increased intracranial pressure, and so better to control ventilation to normal arterial carbon dioxide pressure. The higher the ICP, the higher the PEEP must be to have such a direct hydraulic effect on ICP. And so in general, really, we avoid the beep application in such situations. Only physiological beep, 3-5 centimeter oil. Hyperventilations don't use the cause of ICP elevation is usually progressive. And so further attempt of hyperventilation will raise the intrathoracic pressure, decreasing jugular venous return, and therapy raising the intracranial pressure. And I want also to mention here, avoid jugular cannulation in such situations, because in some situations it leads to clotting and impairing the venous repair from the brain, and so avoid the jugular venous line. You can prefer the subclavian one or femoral. Fever, as I told, very important. Every 1 degree Celsius increase cerebral metabolic rate by 7%, and so you have to decrease the temperature of your patients, to decrease carbon dioxide production and decrease oxygen reflux, oxygen availability, and also fever should be controlled through antibiotic if the patient is infected. Barbiturate coma, steroids, we're not using steroids now in traumatic brain injury, or even in spinal injury also using it, no need. Only in some vasogenic edema and brain tumors. Barbiturate coma, we can use barbiturate to increase the ICP in refractory situations. We can use loading dose 10 to 20 milligram per kg, followed by an infusion of 1 to 5 milligram per kg per hour. And EEG is mandatory here to predict the state of your patients. And you have to suspect hypotension, poikilocerna areas, vasodilatation, and hypotension, renal problems, myocardial depression, edema, immune suppressions, and unreactive large pupils from pain to Operative management, lastly, we have to speak about operative management in mass lesions, especially if an epidural hemorrhage is exceeding 30 centimeters, 30 cubic centimeters, regardless of Glasgow coma score, you have to subject the patient to decompression surgery. If the patient also suffering from score less than 9, clot thickness more than 15, midline shift more than 5 millimeters, or focal neurological deficit, you have to interfere and evacuate the blood, evacuate the epidural hemorrhage. And subdural hemorrhage, if it is exceeding 10 millimeters or greater than 5 millimeters, regardless of the neurological condition, you have to wait blood as soon as possible, of course, especially within the first 4 hours. You have. In parenchymal lesions, blood in the parenchyma and the patient, your patient progress, exhibiting progressive neurological deterioration, better to and refractory ICB or signs of mass effect, you have to evacuate, especially if exceeding 20 centimeter volume or with midline shift more than 5 millimeters or exhibiting external compression on CT scan. Also greater than 50 centimeters in volume should be open. Bifrontal decompressive craniectomy is especially in refractory post-traumatic cerebral edema and resultant intracranial hypertension. Also decompressive procedure like subtemporal decompression and temporal lobectomy and spheric decompression craniotomy. All these could be applied to decrease the intracranial pressures and save the life of the patients and decrease the compression, especially of the brain stem, which may lead to brain herniation and death. Early, especially decompression in the first 48 hours, very important, especially in cerebellar hemorrhage, because we are afraid of compression on the brain stem. Also in stroke, medical condition in stroke, especially with massive infarction, we have to make a craniotomy as wide as possible, and this will save the life of the patient. I think this is the last slide and the very important slide. You have to take care of other items of your patients. Corneal protection, very important to avoid corneal abrasions and eye injury. Early enteral nutrition, very mandatory, especially even with trophic feeding, small feeding, enteral feeding, and if your patient exhibiting malnutrition, especially by day 5, 6, you have to supplement with TPM. Gastrointestinal bleeding prophylaxis also through H2 blockers and proton blockers is very important, and thromboembolism prophylaxis, especially in those patients and in general in ICU patients. Thank you for your attention. I'm ready for any questions.
Thanks, Prof. Samir, for the thorough lecture, and so it was very brilliant and very conclusive also. We have 2 questions indeed. But there was actually a cut in the meeting. So as I remember, one asked about the Presidex or dexmedetomidine role and sedative effect for patients who have high ICP. Do you recommend or you have experience with that? Back to you.
Really, Presidex is very important, very good in such situations, and if even with high blood pressure, we can using it first, because as you know, it is an alpha-2 agonist and decreasing the blood pressure and leading to bradycardia. So it is optimum to use it for many purposes, to decrease the delirium, to improve, to avoid any anxiety, and also as weak analgesic and as a sedative effect, and also as antihypertensive. Of course, small effect, antihypertensive effect, but we prefer to use it more if it is available, because it's not available in, but take care of severe hypertension, of course.
Thank you very much again.
And sorry, I mentioned the clinidine. In some situations, in some hospitals, no dexmedetomidine is not available. You can use clinidine, also, but non-specific. Clinidine non-specific. Dexmedetomidine is specific.
And what's your preference when you use, when the patient has a spike on ICP? Would you go for mannitol, or you will prefer to go to hypertonic saline 3%? And in Ireland here, some of the consultants would also use hypertonic saline 8%, like 100 ml, and give to the patient with very high ICP just to control him for his chronic.
Of course, Dr. Omar, it is, if the ICP is too high, you have to use all means of decreasing the blood, the ICP, especially the osmotic factors like 3% or more than 3%, as you said, or mannitol. But I want from our colleague now, I have a notice on the using of hypertonic saline specifically and mannitol. Please try to follow the CT of your patients in ICU after using the hypertonic saline and mannitol. I have no comment other than this point. Please try to follow your patient, your CT for your patients after using mannitol. I saw many patients after they suffering just from small edema or small primary injury, really after 2 days, extensive ischemia and extensive infarction. I don't know because I not make a research, a great extended research about this point. But this point very important, and I think we will find some results or some advice about using osmotic factors in the future, like hyperventilation. At start of hyperventilation, we're using aggressive hyperventilation, but the CT is deteriorated after. So please try to be meticulous in using your osmotic factors. This is my observation.
Thanks, appreciating your advice. And I think there is no more questions to Prof Samir.